Good afternoon, and welcome to the Health IT Safety webinar series. Today's topic, our 10th and final in this series, is on a roadmap for a proposed National Health IT Safety Collaboratory. I'm Doug Johnston from RTI International, and I'll be your moderator for today's session. Next slide. As we get started, there's a few housekeeping items to review. If you have any questions, please type them into the questions panel at the lower right of your screen. We'll review your questions and have time for discussion after all of today's presentations are completed. Note that all telephone lines are muted and today's session is being recorded. Closed captioning for today's session is available at www.captionedtext.com, event number 2731688. Slides and a copy of the recording of this session will be posted at healthitsafety.org. For general questions about the webinar series, please contact healthitsafety@rti.org. Next slide, please. The Health IT Safety webinar series is funded by the Office of the National Coordinator for Health IT and is being conducted by RTI International, a not-for-profit research institute, as part of a year-long project to develop a roadmap for a Health IT Safety Collaboratory. Additional information is available at healthitsafety.org. Next slide, please. We'll have 4 presentations in today's session. First will be Dr. Andrew Gettinger, who will start by discussing the need for a National Health IT Safety Collaboratory. Next, I'll talk about and review a process for following the developing of a collaboratory roadmap. Dr. Stephen Stack will discuss the collaboratory vision, goals, attributes, and core functions. And finally, Richard Landon will discuss the collaboratory operations and funding model. Next slide. Before we begin, I'd like to introduce today's presenters. Dr. Andrew Gettinger is Chief Medical Information Officer in the Office of the National Coordinator for Health IT at the U.S. Department of Health and Human Services. Dr. Gettinger is also Professor of Anesthesiology, Adjunct Professor of Computer Science at Dartmouth, and Senior Scholar at the Koop Institute, Gesell School of Medicine at Dartmouth. He was formerly the CMIO for Dartmouth-Hitchcock and Associate Dean for Clinical Informatics at Gesell. Dr. Gettinger has been an active participant in health IT policy development and implementation on a range of issues, including privacy and safety. He recently completed service in Senator Orrin Hatch's office as a Robert Wood Johnson Health Policy Fellow, and Dr. Gettinger is currently interim lead on ONC's health IT safety-related initiatives. Dr. Stephen Stack is president of the American Medical Association and a practicing emergency physician. He is nationally recognized for his expertise in health IT and was chair of the AMA's advisory group on health information technology. He served on multiple federal advisory groups for the ONC and was the AMA representative on the Health IT Safety Collaboratory Roadmap Task Force. Dr. Stack was medical director of several emergency departments and is a graduate of the College of the Holy Cross in Worcester, Massachusetts. He completed his medical education and training at The Ohio State University. Next slide. Richard Landon is Director of Regulatory Affairs at QuadraMed, where he represents QuadraMed in federal regulation and national forums relating to their clinical health information technology products. He currently serves as Vice Chair of the HIMSS Electronic Health Record Association, or EHRA, Patient Safety Workgroup, and was the EHRA liaison on the Health IT Safety Collaboratory Roadmap Task Force. Rich earned his master's degrees in public health and business administration from Columbia University, and his background includes hospital administration, electronic claims, and data interchange standards. And finally, I'm Doug Johnston, Director of Health IT Policy at RTI International, where I focus on providing research, evaluation, and technical assistance to federal agencies in emerging areas of health IT policy. I'm also the project director for this initiative to develop a roadmap for a national health IT safety collaboratory. Next slide. So I'd like to hand it over now to Dr. Andrew Gettinger, who will lead us through our first presentation on the need for a national health IT safety collaboratory. Andy, it's all yours.
Thanks very much, and thank you all for attending this afternoon. This is an important opportunity for those of us who worked hard on the roadmap to articulate why we wanted to do the roadmap and sort of what we see coming forward. So, first of all, I have the usual disclaimer about that's required whenever a federal official speaks. Can I have the next slide? So why do we need a collaboratory, or why do we call it a collaboratory, or instead of a center? And I think it's important that we use language precisely. And collaboratory evokes, in its definition, a non-bricks and mortar entity, and that's what we're proposing. And the notion for why we need something like this really came from a number of prior HHS and other health IT safety initiatives where the evidence base that health IT, while it does promote general safety, also creates some new safety risks along the way. And the best way to deal with that is not only to identify them, but to do it in a fashion which is non-punitive, where there can be shared learning and shared responsibility. And the various stakeholders that participate in that include folks from individual clinicians, institutions, organizations that specialize in patient safety, the academic community that has great expertise in safety. And so bringing developers, patients, all of those folks together in a place where we can actually work on this jointly is our goal. Can I have the next slide? So there's a fair bit in writing, all of which is very accessible, going back to a project that ONC chartered in 2011 with the Institute of Medicine, now the National Academy of Medicine, where they came forward with a very useful and still quite valid study on health IT and patient safety. We, ONC, responded in December of 2013 with our health IT safety plan. As some of you know, Congress, in its most recent authorization for the Food and Drug Administration, asked ONC, FDA, and FCC to report back on health IT, and that's the FISASIA report, which was published in April of 14. And now this is the latest effort, which is the Health IT Safety Roadmap. Next slide. And the Health IT Safety Roadmap is part of the project that Doug and his colleagues at RTI have worked fairly tirelessly on for the past year. It's a one-year scope of work followed by an option year, and there were three main tasks in this contract. One, establishing a task force of nationally recognized stakeholders with both expertise and interest in trying to solve the problems that have come to the fore, and to produce a roadmap to help guide ONC, the other federal partners in this space, AHRQ, CMS, FDA, and others, on a path forward, but to concurrently do education and engagement. This seminar or webinar is actually part of that education initiative, and then do some analysis and research on health IT safety. Next slide, please. So this is the actual report. You can access it at www.healthitsafety.org and download it. It is very useful, and in fact, this entire webinar is derived from the actual report. Next slide. So I'm going to talk about some of the examples again. Also from the website, you can see the entire webinar series, and you can see that they're really pertinent topics in health IT safety, done by real national experts who are sharing their knowledge and expertise in their work. I'm not going to go through all 10 of them. It's easy for you to find them on the Health IT Safety website. Next slide, please. So in terms of analysis and reports, this is one example of a series of reports that we chartered. This is CRICO's report. CRICO is started as the Harvard Risk Management Liability Claims Group and is extended far beyond. Harvard is really now a national player in this space. And we asked them to analyze and report on health IT related events in their database of adverse events. And it was only, we asked them only to identify cases where health IT was implicated in patient harm. CRICO applied their taxonomy to categorize safety events as part of that initiative. It's the first time they had used their taxonomy in that space. Can we have the next slide? So what the last part of this important initiative was really to develop a roadmap for a National Health IT Safety Center, or as we're now calling it, Collaboratory or Collaborative, using a planning process that solicited really substantial private sector stakeholder input that would be coupled with federal input. So if you look at later on, you'll see the participants. You can see we achieved that goal. And the secondary initiative was to do these programs and analyses so that we didn't wait for a safety collaboratory, that we wanted to start today improving the safety and the safe use of health IT, and then really more broadly disseminating awareness about some of these initiatives, research, and best practice. And there have been a series of efforts that ONC and others in this space have done trying to promote that as we go forward. Next slide. So Doug, I'm actually going to send it back to you and let you talk in more detail about the collaboratory roadmap. Thank you.
Great. Thanks, Andy. And I just want to pause a moment here. We're getting a lot of questions on audio, and so I'd like to pause for a moment just to ensure that the audio has been activated, and would just ask for folks to stand by for one moment, please. So now I'd like to discuss the process we followed in developing the collaboratory roadmap. Next slide. The process we took was fairly straightforward, and this slide is an overview of the steps that we took, generally speaking. We started by developing a scoping document to define the boundaries or parameters of the roadmap. We then convened a task force steering for one. Also, that the project was intended to build upon prior work by ONC, ARC, and others in health IT safety, and to really foster private sector leadership and engagement in terms of having shared responsibility and shared learning around health IT safety. Next slide, please. So the roadmap scoping document outlined generally the activities of the Collaboratory Task Force. It provided them with guidance on various functions and activities suggested from prior work and areas that were outside of the realm of authority for various funding agencies. The scoping document articulated the goal of this project, which was to produce a roadmap that would outline a 5-year plan for creating a national collaboratory, and included some initial suggestions to serve as a starting point to help task force members facilitate their discussions around both what was in and then what was out of scope. Next slide, please. So this slide provides some additional detail on certain considerations for the development of the roadmap outlined in the scoping document as follows. It discussed how the collaboratory might be, it described rather the potential activities that the collaboratory would support, which could include a range of things such as collecting and analyzing evidence of health IT safety issues, sharing best practices for improving health IT safety, providing support for the development of health IT safety interventions and tools, conducting educational sessions, supporting health IT safety measurement, and overall providing a forum for engagement on health IT safety related issues. It also provided some input on how the collaboratory might be operated and governed to achieve active participation from both public and private sector stakeholders, and then what funding mechanisms might best align with successful and sustainable collaboratory. Next slide. So as part of clarifying the scope of the roadmap, we had to consider what was also out of scope and how the various authorities of the potential funding agencies, namely ONC and ARC, might impact a collaboratory. These authorities indicated certain limitations in the collaboratory's activities, and were used to further inform the roadmap development. So for example, one limitation was that the collaboratory would not be able to engage in direct investigation or surveillance of health IT safety related events, and could not, for example, include performing any functions related to a federal advisory committee, for instance. So these all the limitations are listed here in the scoping document, but were further used to help provide guidance to the task force in their discussions about what the collaboratory should and would not be able to do. But throughout the process, discussions that exceeded these limitations were considered out of scope. Next slide. So the next step we took after creating a scoping document was to convene a task force steering committee and work groups to really serve as the basis for developing the roadmap. The task force and stakeholders we identified through publications and discussions with health IT safety experts, and their job was really to provide input into the roadmap, as well as feedback on the various educational events and engagement activities, and to review and comment on health IT safety related reports and analyses that were produced under this initiative. We also formed a small steering committee of task force members, representative from research, from patient safety organizations, usability experts, and vendors to help inform, really help inform and guide the task force and work group meetings, and to provide some initial review and comment on early drafts of the roadmap. And then finally, we formed 2 work groups comprised of task force members. One focused on core functions and activities, so really what would the center do, and the other on operations and funding, so how would it operate and be funded. And we found that as a very effective way to work between task force meetings to further refine, clarify, and develop ideas discussed in those meetings, and ultimately to produce a roadmap in a pretty short amount of time. Next slide, please. So The task force represented a broad range of health IT stakeholders, including safety and usability researchers, patient advocates, providers and their professional associations, health IT vendors, patient safety organizations and accreditors, medical liability and health insurers, representatives from federal agencies such as the Food and Drug Administration, Federal Communications Committee, Centers for Medicare and Medicaid Services, and ONC and ARC as well. What's important to note here is that we didn't only include these key stakeholders in the task force. The individuals we selected were thought to be and understood to be leaders in health IT safety and had experience with the issues that we would be discussing in developing the roadmap. Next slide, please. So here's a list of the task force members that we included as part of this effort here. We'd like to take a moment to thank them again for their expertise and efforts and their time in developing the roadmap. We'll note in blue here that it's a little grayed out maybe in your screen, but we'll note in blue that those are the steering committee members. But ultimately, we had a good representative number and participation from these task force members over a period of several months to develop the roadmap. Next slide. Here's a high-level overview of the process that we followed, starting with convening a full task force meeting to brainstorm ideas and to outline the core activities, operations, and funding for a potential center, which we then summarized and incorporated into a draft that work groups then iterated and developed additional detail on, brought it back to the task force for consideration and further discussion, and then additional refinement into the roadmap draft. And this process we repeated a few times over several months to ultimately get to the roadmap that Steve and Rich will talk about in a minute. Next slide. And finally, the timeline we followed here was fairly aggressive, but certainly yielded, we think, a great outcome. The task force met between December of 2014 and 2015 and 4 main meetings with steering committee and task force meetings, steering committees meeting after the full task force and work groups in between to refine ideas. Ultimately, the roadmap that we produce reflects a consensus of the task force members on the core functions and activities, operations, governance, and funding models to support a national collaboratory focused on health IT safety. So with that as an overview of the process that we followed, next slide please, I'd like to hand it over to Dr. Stephen Stack, who will discuss the collaboratory vision, goals, attributes, and core functions. Steve?
Thank you very much, Doug. So in the next 6 slides and 20 minutes, I'd like to try to give an overview of the vision, goals, attributes, and the core functions of the proposed safety collaborative. So if we could have the next slide. So on this slide here, we're going to focus on covering the vision, the mission, and then what we will actually propose to do with the safety collaborative. So the vision for this is safer systems and better care using health IT. And we would intend to have a mission of serving as a place where stakeholders, both individuals and organizations, can work together to create a learning system committed to essentially 2 main objectives. The first being using health IT to make care safer, and the second being continuously improving the safety of health IT. In order to accomplish this, we would bring together, as you can see in this diagram, the current broad landscape of participants in the health IT ecosystem who are all working in their own differing ways to try to advance similar objectives for safer care empowered by health IT, but bring them together in such a way that we can collaborate where there's overlap and share our efforts moving forward in a shared common purpose and direction. So I think everyone on the call would recognize that the rapid pace of health IT and EHR adoption has the prospect to yield wonderful benefits for patients and clinical care. And today, of course, we have hundreds of thousands of health professionals and thousands of hospitals who are working very hard to realize these potential benefits. At the same time, safety organizations and researchers, as well as frontline health IT users and stakeholders, have found that there are risks and hazards related to patient safety associated with these new systems and the complex healthcare delivery environments in which they are implemented. For this purpose, or for this reason, the ONC undertook to identify health IT as an area of vital importance, and then created the efforts that Andy and Doug have already outlined for how we've gotten to this point here today. The Collaboratory's operating model as proposed is very straightforward. We'd proposed that there be an executive director who would lead a staff dedicated to various functions. Those functions would be convening, researching, and disseminating, and I'll cover those on a subsequent slide. These functions would support our proposed core activities, and that will be covered on another slide. We would have an advisory board composed of participants in the Collaboratory and members from both public and private sector who would represent the various stakeholders and oversee the executive director and staff. This Collaboratory would have a broad, active set of participants and members, both again from the public and private sector, each of whom would contribute and work both to produce materials and then to benefit from those materials as we work to identify challenges, propose solutions, and then pilot test those potential solutions, and hopefully in a virtuous feedback cycle, progressively innovate to make health IT safer. The Collaboratory is proposed to be started up with seed funding from the federal government. The seed funding would be channeled to a contracted partner, and the subsequent presenter will go over that, for an initial 5-year period. As part of the work the Collaboratory would undertake in that first 5 years would be creating a sustainability plan for how to endure beyond that initial 5-year period of federal startup funding. There are a number of different models that will be described as far as different funding sources, or different, funding levels, and how we might adapt to different levels of funding at the outset. If I could have the next slide. So these are the attributes that the task force felt would be key and central to the work we do. I describe this as how we will do all this work. We intend to be dedicated to shared learning and shared responsibility. The Collaboratory would operate as a forum for private and public sector individuals and organizations who share a common dedication to the objectives of the Collaboratory to exchange ideas, evidence, solutions, and educational resources for using health IT to make it care safer and to improve the safety of health IT. It would also be solutions focused. Using evidence of health IT related safety risks and hazards, the Collaboratory stakeholders would focus on solutions, including prioritizing areas for improvement, identifying possible solutions and pilot testing those solutions, and then disseminating and fostering adoption of solutions that have been found to work, and then monitoring success at a broad-based way. We would also hope to build on private sector activities and initiatives. Very specifically, there was a shared agreement that it is not desired to have the Collaboratory be duplicative to work underway. It's intended to build upon work that is already underway and hopefully to serve as a central organizing point to bring shared common purpose and economies of scale by shared effort to this particular challenge. It would also be committed primarily to clinical users of health IT whose patients would then subsequently benefit because the technology tool being used would be safer, less likely to cause harm, and hopefully much more likely to add benefit. It is very important to note it will be a public and private partnership. There are contributions that both the private sector and the public sector through government have to offer and bring to bear to this particular initiative, and throughout all of this it is designed and proposed as a public-private partnership. A central part of this is that it is a trusted, learning, non-punitive environment. All of the activities of the proposed Collaboratory, particularly those related to health IT safety risks and adverse events, will be conducted in a trusted space. The stakeholders may choose to share analyses of data, examples of safety risks and adverse events, solutions and resources, but always in accordance with privacy, confidentiality, non-disclosure, and relevant intellectual property obligations and laws, and all done in such a way that this is a non-punitive, collaborative, trusted environment. It's important to note, and Rich may go into this a little bit in his remarks, that there is no regulatory component to the collaboratory, that there is no delegation of federal authority into this. This is a voluntary, non-punitive collaboration. And then finally, we intend that the center would operate in a very transparent way. This will be an open and transparent collaboration intended to foster and facilitate the trust of all the stakeholders in the system and to encourage the accountability of every stakeholder for the parts that they own. Next slide, please. Just at the highest level, this is intended to be a broad-based collaboration. So this slide gives examples of the who will do this. We want to involve anyone and everyone, individual and organizational, who has something of value to offer to advancing the safety and efficacy of health IT as a means to facilitate high-quality, affordable health care. And I won't go through this list, but this is just a partial list of major buckets of types of groups. Of course, we will hope to have many, many people from within these buckets and perhaps others we have not identified step forward to be part of this center if we're able to bring it to fruition. Next slide, please. So this slide here shows, I would say, by what means we intend the collaboratory to undertake its work. There are four major buckets here. The first is collaborate on solutions. I think some of this is self-evident here, so I'm going to go over the high level and then maybe fill in a bit. Collaborate on solutions, where we are going to work together to find very targeted solutions to very targeted safety risks or challenges that are identified through our research processes and through input from the various stakeholders. The second area is to improve the identification and sharing of information. And on this, we would very much hope to improve the ways that risks are identified, that perils and pitfalls are recognized, perhaps to help improve the surveillance tools, perhaps real-time reporting available through EHRs, to enable us to capture in a meaningful way those challenges that are prevalent, such that the solving of them would benefit many, many people, even if the magnitude of risk is relatively small, or those things that should be the equivalent of a never event and never occur, and where it is imperative that we take action, even if the volume is small, where the consequences to a harmed patient will be substantial. So we would like to find ways to improve the identification and sharing of information and hazards. Then, as far as reporting evidence, which is the third item here, on health IT safety and solutions, we would want to create a robust way to make sure we widely share and disseminate the findings that emerge from the work of the Safety Collaboratory, and also to demonstrate targeted solutions to very specific issues and to identify for the entire healthcare ecosystem proven solutions to those problems. And then the final would be to promote health IT related safety, education, and competency. We would like to serve as a clearinghouse for health IT safety solutions, and where we may not necessarily always create all the tools, we would certainly like to be able to catalog them and make them broadly and widely available to everybody in a central location in a trusted manner so that people have confidence going there for resources. If I could have the next slide, please. I'm going to cover this at a somewhat high level, and then Rich is going to subsequently walk us through an example, I think. We identified three major functions of the Safety Center as a way to conceptualize how the work would be organized and how that work would be undertaken. These functions are number 1, convening, number 2, research, and number 3, dissemination. For the convening, I've touched on that in the previous slides. We want to convene a broad-based collection of stakeholders who have knowledge, interest, and experience in health IT, and bring them together in a non-punitive, collaborative way to work together to identify opportunities to improve health IT, to identify solutions to current challenges, and then to propose ways that those solutions can be disseminated on a broad scale and brought up to scale as far as their successful adoption in a broad and substantial way. We also then, for our second function, would propose that the center undertakes significant research, both collecting and assessing existing data and analyses and reports, in researching to identify already created solutions that may not yet have become prominently or broadly known or used, and make those available and disseminate those so they can be more broadly used. If you will, I'm blanking on the word I wanted to use here, but disseminating the best in class for solutions for certain problems. We would also want to identify and improve the methods that we use to characterize health IT safety events. Sometimes the way in which we catalog problems and put them into descriptions of similarity or dissimilarity will help us to better identify the leveling of the need for solutions, as well as the type of solutions that might solve a broader array of problems if we identify trends and general themes. And then we do want to have some kind of feedback loop where once we propose these solutions, and if the end user health IT community begins to deploy them, we would like to have a feedback loop to see what is the impact of those proposed solutions, and are they in fact actually helping to make care safer through better done health IT. And the third and the final core function would be the dissemination of this research. And this would be, a view of this would be that it is intended to be widely used for the greater good of all, widely disseminated, and that the key outcome and desired focus is that patients receive and experience better, safer care, and that clinicians are supported in the use of health IT that fosters safety and doesn't increase the risk of harm through our efforts, through a proposed collaborative. And in so doing that, I guess I would say there is no pride of ownership. The pride is in seeing the solution successfully deployed and health IT being better and more safely used. And if we could go to the final slide, please. This slide summarizes the proposed collaboratory's activities and where these core functions, convening, research, and dissemination, would be used to complete an activity. In Richard's talk, which immediately follows mine, he will walk us through an example of how these functions would interact to complete a proposed collaboratory activity, gathering evidence and developing a solution for a health IT safety issue. And with that, I think I've actually ended a little bit early, and I will now transition to Rich for the next portion.
Thanks, Dr. Stack. In my presentation, I'm going to be talking about the operations of the collaboratory and talking about the funding model that will support it. Next slide, please. Here's the visual of what the concept looks like. If you start at the very top, the green bar is the source of funding, which will be from one or more federal agencies as seed money. It will flow down into the host organization as we talked about earlier, through the cooperative agreement with an agency or agencies. And then the host organization will, as one of other programs it supports, the host organization will support the Health IT Safety Collaboratory. Moving back up to the top left of the slide, the collaboratory would be inclusive, open to anyone interested in health IT safety, and could benefit from the activities. All the people who work in conjunction with the collaboratory would be participants. There would be a collection of members who are higher in their engagement levels than participants, and those members would consist of both public sector representatives from the federal agencies and from the various stakeholders in the private sector that we've, I think, presented at least once or twice. Now, in keeping with the FDASIA report, the draft report that was mentioned earlier, and the government's interests, the federal agencies would serve as a funding source for additional seed money and for guidance for the collaboratory through what's called a cooperative agreement. A cooperative agreement is similar to a contract, except that the cooperative agreement is a bit more flexible than a contract, and the key aspect of a cooperative agreement is that it allows the sponsoring government agency to be much more of a participant in the process. The operational model presented in this roadmap is supported by the host organization and funded by the federal agencies. The organization, then, the collaboratory, would be led by an executive director who would be an employee of the host organization and supported by a team of staff to support the functions that Dr. Stack reviewed, the convening, the research, and the dissemination activities. Supporting the executive director would be an advisory board made up of selected groups of public and private sector members. The advisory board would serve to direct and prioritize
Welcome to the webinar. You have entered as an organizer and may now speak to any other organizers or panelists on the line. When you are ready to begin the presentation, press the Start Broadcast button on the GoToWebinar control panel to allow all attendees to hear you. This system will notify you once you begin your broadcast.
Solution.
The broadcast is now starting. All attendees are in listen-only mode.
So the work groups would produce various work products such as solutions, or they may be educational resources rather than solutions. And the work group product that then would be reviewed for approval or endorsement by the Collaboratory Advisory Board and Executive Director. Additional information about how those processes would work and the roles of each group can be found in the full roadmap, which, as Dr. Gettinger mentioned, is downloadable. The collaboratory, I would again stress, would be inclusive. It's open to anyone interested in health IT safety and who could benefit from the collaboratory activities. As a public-private partnership, the optimal collaboratory would include broad participation from a range of stakeholders. Participants would include individuals and organizations with an interest in health IT safety. Participants would be able to provide input into the collaboratory's activities, and they would receive work products, including evidence reports and solutions, and participate in education and training sessions. Participants would be likely those individuals, organizations from various collaboratory stakeholders described previously by Dr. Stack. Collaboratory members, and again, this is in contrast to collaboratory participants, would constitute a large subset of participants, the main difference being the level of commitment to engage in collaboratory activities. Participation in the collaboratory would be free and open to everyone. Again, stress, free and open. Participation, members would be expected, however, to contribute to the collaboratory in several ways, foremost by identifying areas of common interest to work on together. They would agree to share evidence and to share analyses. Let me also stress that these analyses, as we've stated before, but I think it's important to reiterate, that the data that we will be using will be de-identified, both of patient information in particular, but other types of identification in general, to keep to the theme of a non-punitive and learning environment within a safe space. So this evidence and these analyses would be shared, and the work groups then would, the members would work within the work groups to define and offer solutions, whether those be practices or tools, to address those types of events. Collaboratory members may also be asked to provide in-kind contributions and funds to support the collaboratory activities. We'll get to the funding in a slide or two. Membership in the collaboratory's initial years would generally not be contingent upon a participant's ability to provide any contributions. However, very important, we get as many stakeholders involved as we can. Next slide, please. So this slide kind of repeats what I just went over in terms of who are the categories of participants, members, what is the funding agency, the host agency. I think the only things we haven't really talked about already is the staff. And as Dr. Stack mentioned, described, we've got convening staff who will essentially help organize the work groups and provide the infrastructure for the work groups to function efficiently and effectively. The research staff will focus on existing evidence. The collaboratory will not by and large, do primary research, but the research staff will conduct environmental scans, evidence scan, and provide to the members of the work group the information that exists, along with identifying some of the gaps in information, so that the work groups will not have to start from scratch or reinvent wheels that are already out there. The dissemination staff will promote and distribute the collaboratory work products, whatever those be, evidence or solutions or tools, and assist with the implementation and the evaluation of work products and develop and support web-based directories. And again, let me stress that this, after the information, the solutions, the tools are disseminated, there is the process that is intended for the Safety Center to continue to look at the products and watch as they are implemented, taken up by industry or not taken up by industry, and then feeding back to continue the process of evaluating potential to improve. Work groups we've talked about, so I won't go into those again. Next slide, please. This slide is kind of an eye chart. I won't go into it in detail, but at a high level, the first three columns from the left are what the advisory board and the executive director and the research staff do to begin to identify what are the issues that are high priority to the industry, that we have evidence around. What is that evidence? And those issues are high priority, and there are possible solutions or improvements that can be made. So if you look down at some of the detail, you know, as we talked about before, in the first column, you're asking the members of the collaboratory to share existing information and data and experiences. In the second column, we're collecting the evidence, identifying, synthesizing findings is a key. And then in the third column, we're coming to some conclusions, or at least at the advisory board, executive director level, to identify which of all those issues are amenable for going forward and actually developing the work group to work on. The next three columns, columns 4, 5, and 6, talk about the work group activities and the process and coming together, filling in the gaps that are identified, and identifying the solutions or the best practices or the tools that may help to address the needs. The column number 7 then is kind of an oversight process by, again, the executive director and the advisory board to review the output from the work groups and to ensure that the work product is a good work product and that it is consistent with other evidence, other solutions, other products coming out of other work groups. In column 8, that's more the evaluation and evaluating the impact and of the disseminated products, looking at what happens once the collaboratory disseminates a recommendation or a product or a tool. Does the industry adopt that? Do they move toward it? Is the adoption process smooth? Are there problems that arise? Does the tool need or the product need fixing? And then in column number 10 on the far right, back at the advisory board and executive director level, continue the process of that review, and based on that review, determine the next steps or the next cycle. Next slide, please. Okay, again, back into the structure that's proposed by the roadmap for the collaboratory, and again, focusing on oversight and accountability, who's responsible. The host organization is primarily responsible, and it will provide the initial governance in accordance with the term of the cooperative agreement. Again, the cooperative agreement is essentially the tool, the legal vehicle, the instrument by which the sponsoring federal agency or agencies provides funds to the host organization for running the collaboratory. And the advisory board, we've talked a little bit more about that. Its purpose is to guide the executive director on collaboratory activities and priorities. This is the high level, sorting out what opportunities there are to work on, ruling out opportunities that would provide a low benefit to the patients and clinicians, or a low probability of having a solution or a fix. And then the advisory board would also broadly oversee the execution of the collaboratory operational plan. Next slide, please. The funding model objectives, and this was included in the charge from the Office of the National Coordinator, and the charge was to, for the roadmap process, to estimate the funding needed to support all the functions of a, quote, optimal, unquote, collaboratory. So if in a perfect world, in an optimal world, how much funding would it take? And then second, to estimate the funding and functions if we only get 75% of what the optimal level is, or 50% of optimal. So essentially a drill down. If we can't do everything, what are the most critical things we can do given the funding available? And also then to identify the functions or activities of the collaboratory with an order of priority. So convening work groups to focus on specific high priority areas. And again, as I mentioned before, a couple of slides back, what are the areas that it is most likely we can successfully affect to improve overall safety for the patients and for the system? And then also to engage in what's the most effective means for doing the research and doing the dissemination. Next slide, please. In its review, the operations work group of the advisory task force on the roadmap project did a high-level review of multiple organizational structures and associated funding models that existed in the country, with particular emphasis on what exists in healthcare, but not exclusively looking at healthcare-related models. We looked at organizations such as charitable foundations, the Markle Foundation, Robert Wood Johnson, the Pew Charitable Trust, among others, and look what they did for funding, researching, and convening. We looked at the Patient-Centered Outcomes Research Institute, the CORI. We looked at the National Transportation Safety Board, NTSB, and specifically we looked at the SIAS system that is run by the MITRE Corporation in terms of bringing a complex system together to provide data in a learning environment. We looked at some of the AHRQ funded operations. we looked at ECRI, which is a private nonprofit that generates income through some core services and contracts. And finally, we looked at with Healthy Way, which was initially federally funded but has now spun off into a private entity and is funded by participation fees and some other revenue sources. So we looked at those models, and then we looked at the what are the key attributes. We concluded that because patient safety, HIT safety, is a general good, and that there is no real advantage, return on investment for any early adopters, early funders. And we also looked at the issue of free riders, and in this case of patient safety, free riders are a good thing, but free riders have implications in terms of funding. So we want free riders. So the conclusion of the operations work group is that we should use 100% federal funding for seed money, and then transition, as we'll go into in a later slide, transition over to a mixed funding source of private sector funding along with some ongoing federal funding. We also looked at independence is desirable, but multiple pieces are required to put the collaboratory in place. Congressional approval is, or legislation may be required. In the primarily what we're talking about in this bullet is the budget aspects of it, because none of the existing federal agencies have a full line for something called the HIT Safety Collaborative, and there is no private funding available at this point in time for the reasons I just described. Secondarily, congressional involvement may be required as we continue to define the requirements for what this safe space concept is that Dr. Stack had described in his presentation. And then finally, the required attributes for the funding model is it had to provide support for the convening, the research, and the dissemination aspects that we talked about on the earlier slides. Next slide, please. So the proposed funding source, as I alluded to, would be a 5-year cooperative agreement from a federal agency or agencies to the host organization. That host organization would be chosen and the cooperative agreement awarded through open competition. Having a host organization that is experienced, that has other initiatives, that has the infrastructure in place, that's already in the healthcare or similar space, would streamline the launch requirements to get the collaborative up and running. The collaboratory would function as a program within the host organization's portfolio of programs, and the host organization would be able to support the mix of direct agency funding and involvement, and the host organization flexibility to work with both public and private sector to achieve sustainability and autonomy over the 5-year process. So the phased approach. Phase 1, the first year would be startup, just getting things established up and running. Phase 2 would be years 2 and 3 of the 5-year cooperative agreement. That would establish the work groups, start the development of the work products, start the research and the early stages of dissemination. Phase 3 would represent years 4 and 5 of the cooperative agreement, and that would mean the gradual ramping up of the long-term financial support, be that public sources or private sources, most likely combination of the two, that would get the organization into a steady state where it would be no longer dependent on a single or multiple federal agencies for a cooperative agreement or for a contract. Next slide, please. Staffing. The funding model inputs we used were all bottom up. This started with a 0 and said, okay, we need this, we need that, and then added up. We did not start from the top and say, for $20 million, we can do this. So we built from the bottom up, kind of a zero-based budgeting approach. The staffing that the work group came up with recommendations for would include a full-time executive director across all 3 scenarios. And again, those 3 scenarios are 100% of optimal funding, 75% of optimal, and 50% of optimal. The second staff position would be full-time convening lead staffer across all 3 of those scenarios. The rest of the positions would be full-time or partial FTEs, depending on the funding levels. The other costs included in the funding model included the infrastructure, just the cost of facilities, telecommunications, bookkeeping and whatnot, travel costs, and the assumption being in here that the work by the work groups and by the collaboratory in general will use some web-based meetings, but also will use some face-to-face meetings as appropriate. Other costs include meeting support and consultants. Again, the volunteers will provide an awful lot of the work and the effort and the energy for the collaboratory, but the volunteer work can be and should be supplemented by consultants as needed to ensure the quality and the success of the work products. The collaboratory participants and the members, and again remember these are in-kind contributions, at least in the earlier years. The advisory board members will be volunteer and will be unpaid. The work group participants will be volunteer and will be unpaid. Next slide, please. Okay, these are the numbers that we came up with at the 100% of the optimal funding, $17.8 to $20.6 million over 5 years. Again, the seed money coming mostly or exclusively from the federal contribution in the earlier years, gradually shifting over to combination private and public in the later years. At a 75% of optimal level, that would mean a 5-year funding range between 12.9 and 14.9 million, and at the 50% level, 9.1 to 10.5. Now, obviously, as the funding levels diminish, the scope of work and some of the the number of work groups, the number of products, the number of projects we can do would, of course, diminish. But again, as I mentioned earlier, this is all being done in the context of the advisory board identifying and prioritizing problems and opportunities. And I think that brings me to the end of the slides, so move it back to Doug.
Great, thanks very much, Rich. And I want to thank our presenters, Dr. Andrew Gettinger, Dr. Stephen Stack, and Richard Landon for their talks today and for their efforts on the Collaboratory Roadmap. I also want to thank the audience for their patience with audio issues. I understand that there's been difficulties with the audio today. I want to apologize for these and note that we'll aim to either reschedule this webinar and certainly make the audio recording available so that folks can hear all the great talks that were given today. Next slide, please. So to end today's presentations on a proposed National Health IT Safety Collaboratory Roadmap, the roadmap contains certain considerations for implementing it. And one is that the roadmap's really intended as a starting point for a national collaboratory. It doesn't cover everything, not all potential activities. It really emphasizes those areas that the task force thought as being of highest value, namely convening stakeholders, identifying issues, and developing and disseminating solutions to those issues. The roadmap in this regard focuses on improving health IT safety, and a lot of it, when you read it, you'll see it focuses on addressing potential risks and hazards. However, the goals of the center, like the goals of health IT safety and efforts, the goals of the collaboratory, I should say, like the goals of many health IT safety related efforts, are to also see and share learning about how health IT can be used to make care safer. Another important consideration here is that the task force felt that convening a diverse mix of stakeholders would be paramount as part of creating that safe space for stakeholders to work together on identifying solutions to health IT safety risks and hazards, but that participation should be broad and encouraged across the healthcare system as these technologies are adopted and used by many. The collaboratory also should support development of safety cultures in participant and member organizations. So a larger consideration here is not just a safe space or a forum for identifying issues and developing solutions, but also, in turn, helping organizations themselves develop cultures of safety that have practices around the identification and response to health IT safety risks and hazards is an important, hopefully, outcome from this effort. One thing, too, in closing, is that this process, identifying a task force, convening them, developing the roadmap, really helped build a foundation for collaboratory. And we hope that it can be used moving forward if we're able to get congressional agreement and funding for these types of efforts, serve as a basis for developing a national collaboratory. So with that, next slide, please. I'd like to thank everyone again and apologize for the audio issues. This slide includes speaker contact information. Please email us if you have any questions. Also, on the right side of your screen, you'll see that there's a link to the healthitsafety.org website and the webinar series there. All of the webinars, slides, and audio files for most of them are available on the site, healthitsafety.org/education. Or you can simply contact us at healthitsafety@rti.org if you have additional questions about any of the webinars in this series. Next slide. Here's the website for those of you who'd like to visit it. I would turn now to any questions that we may have, maybe those that aren't about audio issues so much. But let's see if there are any questions from the audience regarding the Health IT Safety Collaboratory Roadmap. Okay, one question we have is, where will the research staff and dissemination staff come from? Will they be paid employees of the host organizations? So I'll start with answering that and would ask others to chime in. This is just for the benefit of the audience, but those would be part of the center. Part of the collaboratory itself. They would be employees of the collaboratory itself. Okay, let's see if there are any other questions. The next question we have here is from Robert Morton, and the question is, who will present this to Congress for funding? Andy, if you're still on the call, would you like to comment on that?
Oh, absolutely. So we will, as part of our budget requests, put that in our budget requests, and typically what happens is congressional staff will ask us for clarification or technical assistance and explain what the request is, and perhaps also we will engage the other task force members to help in that explanation. It's a little bit of a different concept, this notion of not proposing a regulatory agency, but proposing a really a voluntary place where all the interested parties can actually participate and feel comfortable participating. One analogy is the ASIAS model, which is the airline safety program that is done voluntarily, and then it reports out information to various federal agencies.
Great, thanks, Andy. The next question we have from Alex Dimmitt is, does an organization as a whole need to sign up, or can individual members from an organization sign up? And the task force thought, and this is discussed in the roadmap, but the task force thought that individuals as well as organizations could be participants or members, so that, again, as Andy was just saying, that we would have wide representation and people would feel comfortable, organizations would feel comfortable participating in the collaboratory. Those are all the questions that I've received so far. I'll wait another moment to see if there are any additional questions. Again, if you've been listening and watching along, if you have a question, in the bottom right side of the screen, there's a questions panel. Simply enter your question in it, and I'll review it and we'll respond. The next question we have is from David Birnbaum, who asks, will the Collaboratory welcome participants globally or just within the USA? I think the response, we haven't encountered this yet. We didn't, I think, and I would ask the task force members, Andy and Steve, to comment on this, or Andy as well, but we really haven't discussed international participation as much. That initially the Collaboratory would focus on more domestic organizations and issues. But I think it would welcome learning and resources, what could actually be learned from other settings, including international settings, and resources developed in those settings as potential solutions. Andy, Steve, or Rich, could you add to that at all?
I think. Go ahead.
Go ahead, Steve.
I think you've got it right. The focus is clearly on what we can do to make health IT safer and better in the United States. But that being said, I said we had no pride of ownership in the product. We just wanted to help patients have better outcomes benefited by well-done health IT. And so if international communities can benefit from that, I think we would be thrilled for them to benefit, for their patients to benefit. And likewise, if they have things that we would benefit from to learn from their experiences, I think we would be grateful to have that. So the focus, I think, would clearly be domestic U.S., but since the participants themselves would be voluntary, uncompensated people participating in the work groups and the projects, I don't see any reason, nothing that we did as a task force would preclude or discourage others from outside the country from participating, other than the need for them to support their own participation.
And this is Rich Landon. I would concur with that. I'd also point out that there's a lot of what already underlies the standards within the industry, both on the clinical sides and the EHR development side, that are already international standards. Some of the guiding things for quality management systems or for usability or accessibility are already international standards. So I would see that trend both continue and accelerate. Nonetheless, as Dr. Stack pointed out, the focus of the Collaboratory itself would be domestic, or primarily domestic.
Great, thanks, Steve and Rich, for those additional comments there. Received one comment making sure that we include U.S. territories as well, and I think what you just said, Steve and Rich, would certainly include their participation. Okay, we still have time. We're about 15 minutes before the end of the session. We still have time for additional questions should any audience members have them. Well, I would note, although no one's asked, I think in the past, we've received several emails through healthitsafety.org asking for, how individuals, for the most part, but organizations too, can get involved with the Collaboratory. So generally we get questions about how can I participate, and I would note that moving forward would encourage anyone who's interested to please go to healthitsafety.org, email us and submit your interested information, including areas of expertise or where you think you can make a contribution to the discussion around the identification of health IT safety related issues or solutions. And RTI will be, we've already compiled a large list of those who have expressed that interest, and will be continuing to update interested parties moving forward on the status of the Collaboratory and on getting involved. So though it doesn't exist today, we are certainly building a communications list and will be updating interested parties moving forward on any events. And certainly the website, healthitsafety.org, will have these updates as well. So I'd like to see if there are any additional questions, and if not, we'll be closing early. I'll give participants one more moment to input any questions they may have. Okay, well, I'd like to thank all of the presenters again, apologize for the audio issues, and thank the audience as well for your attention and participation in this 10th and final Health IT Safety webinar on a roadmap for a National Health IT Safety Collaboratory. Have a great afternoon.